Thank you. Thank you for that wonderful introduction, Jeff. And can I just say, I feel absolutely no pressure following one of my role models and mentors, her parties, in standing here today. No pressure. Thank you very much. And after lunch, which is better, I guess, than before lunch, but I also feel a little bit, as I said to someone at lunch, like a fish out of water. I'm standing where real researchers stood about an hour and a half ago, and heard some wonderful things that are bubbling around in the minds of people in my profession and in the behavioral health arena generally, that I think of as the next wave of what we will do to do exactly what Herb talked about, make mental health and mental illness and psychiatric disorders much better appreciated for the challenges that they present, but also to make it easier for people to access information around what can be done that will be helpful with these things. So I'm honored to be here, to have been invited, and thank you, BBR, for making this happen. When I was asked what I would love to spend my 15 minutes talking about, I thought, well, I'm going to be with researchers, so I really ought to say something about research. I mean, it just kind of fits. And you should know, by the way, that I'm a born in the South Southerner. And so if I lapse into some Southern drawl every now and then, that means I'm just really getting into the spirit of things. And I'm losing my professional focus where I speak like this a lot. But one of the themes for my presidency, and I am honored to be the president of the American Psychiatric Association, over 38,000 psychiatrists in the United States and internationally, largest psychiatric organization in the world, the oldest in this country, and so we've got a rich tradition and history of doing things in support and in service of people with mental illness, as well as the profession. But I think it is safe to say that as part of my priority during my presidency, having a focus on some issues that have heretofore not been well researched, not been well served by the body of psychiatry generally, has become one of my passions. And certainly my theme today of how research can help us address the issues around health inequity is one that I feel very strongly about. I thought I would start with just a little bit of a background in terms of what I mean when I say health equity. And so I use the World Health Organization definition of health inequity as a difference in the distribution of health status or health determinants between different population groups which are unnecessary, avoidable, unjust, and unfair. And so for me, the notion of combining and pairing health status with social justice and health equity are all sort of on a continuum in my thinking. Inequity is different from inequality in ways that I'm sure everyone can understand. And while there may be in the health inequities many, many, many inequalities, the reality is the outcome is unnecessary, unavoidable, unjust, and unfair. So when we come to talk about the differences in healthcare accessibility between the various socioeconomic groups that can be interpreted as an inequality as well as an inequity, there are some differences that we have to resolve. If in fact there are differences in physical capabilities because I'm old and you're young, then that's really not an inequity because that's unavoidable. That just happens with age, as some of us know. If there are differences, though, that are due to biological variations, fully informed decisions that are made to participate in high-risk behaviors, whether it's drinking, smoking, promiscuous, unprotected sex, and the like, and that the chances for those things leading to health issues, then again, we might consider them inequities, but we have to take a look at how to describe these inequities that also represent inequalities across the groups by virtue of the unjust nature of them, the unfair distribution of the resources necessary to overcome them, and we wind up at that place that we all now talk about as social determinants of health. So the other things that are different about these two, health inequalities can be measured quantitatively. Health inequities really cannot. Because when you're talking about a health inequity, you are using a judgment about a social justice issue related to an inequality, but it depends on that inequality being present in the context of whatever that local community is that you're working in. Health inequalities can be attributed to free choice, biological variations, physical environment, and other factors that are beyond the control of the individual who's concerned. The health inequity, however, relates to that social and environmental factor, including income, social status, gender, education, physical environment, those social determinants of health that are very likely associated with inequity in social status. We have to start looking at what's happening upstream when these issues appear and serve to be health issues for people. And one of the things that happens that's upstream, creating some of this downstream inequity, is of course power and privilege. Now, that's not the theme for my talk today. That's a whole other talk for another day. But I come from Memphis, and so I often quote Martin Luther King, who, believe it or not, had a real strong involvement in health issues during his day. And he talked about inequity without calling it health inequity. He talked about it when he spoke these words: whether it's the health inequity is the role of power and its ability to achieve a purpose. Whether that purpose is for good or bad, and these are his words, power directs resources and how they are or are not used, and plays a role in our efforts as a nation to reach our full health potential. So the future academics, intellectuals, and researchers in the audience and beyond are the ones who are going to have to look at how we address these influential decisions that have as much to do with power and privilege as with anything else in our culture and environment. And we'll leave that to talk about another day. But I don't think it's absolutely necessary for me to focus on power today, because I think we can all agree that any effort that we make to achieve health equity for underserved, disenfranchised populations can be very overwhelming. It's a lot of work. I'm here to tell you, however, that across the country, there are people working in various communities to do just that. And they're making some progress in these challenges in ways that are important to their community by collaborating across organizations and treatment systems and identifying strategies for working with those communities to determine what issues are critical for them, what's at the top of their list of things to be done with respect to improving health status in their own communities. And while federal, private, and academic institutions can play a role in closing the gap that we currently have between the most and least advantaged in our society when it comes to health care, the growing consensus is that, like Tip O'Neill said about politics, all healthcare improvement is in fact local. It's what people in that community determine are the priorities, and how we, those of us professionals with all of our ideas and strategies and models and other things, help them to achieve those goals. There are various examples that I can cite and will for a few moments. The National Academy of Medicine has a culture of health program. And in that program, they have seeded money into communities that are creating those building blocks that will drive change where people live, work, and play. And because I'm from the South, we always add at the end of the play and pray. Memphis is the buckle of the Bible Belt, for those who don't know. And so a lot of the work that we do in the area of achieving health equity comes by partnering with faith communities. But that's also a topic for another day. Now, we know that it is programs like this, however, through their efforts to achieve health equity and directly address those conditions that led to the development of that inequity, that will most likely influence and positively impact the communities where these things are being done. However, we're still a few steps away from positively and consistently translating that research that is done to achieve the health equity into better practices and policies on the public health arena so that we can lead in the area of making major community health improvements, so that we are at the forefront of controlling chronic diseases and moving populations in these communities where this work is going on closer to better health and to healthcare equity. I work at an academic medical center, and we too can play a role in how we can work to reduce these health inequities. The AAMC, the American Association of Medical Colleges, and some of its member medical schools have partnered with various communities in areas where some of their schools are to create very innovative community-based research projects with preventive medicine, for example. At my home institution in Memphis, at the University of Tennessee, we've created 2 programs, one with our pediatrics and psychiatry departments, working in partnership with the area law school, with our public school system, and again with our faith community, to create some interventions that address serious children's health issues that we face in our region, 2 of which are severe asthma and obesity in childhood. As part of a statewide initiative, we are now joined at the hip in partnership and collaboration to overcome those things that are related to what we now know and call adverse childhood experiences, and the health inequities and poor health outcomes in adulthood that come about as a result of those things. We're trying to get upstream of the development of some of these chronic problems. We have another project in the area of addictions that involves our addiction medicine center, our family medicine and internal medicine departments, psychiatry and anesthesia related to pain medicine and its role in addictions. The collaborative work that is being done by this partnership in our underserved community is now being studied to determine the effectiveness of all of these programs for these populations, the children of addicted individuals, as well as those addicted individuals themselves, in terms of improving the overall health and well-being of both of those groups. These 2 issues, by the way, were identified in a community-wide health survey that was conducted by our public health department. There are other promising programs. RWJ's program about the vision of a society in which everyone has an equal opportunity to live the healthiest life possible, where they say we first have to identify health disparities. Then we've got to work to change and implement better laws and policies and systems and environments and in practices that will reduce health inequities in order for the opportunity and resources for improved health to be available to people. We have to begin to do a better job of evaluating and monitoring those things within those communities that we're working with and engaging those communities in helping us to set up measurements and evaluation schemes. And then we've got to do what we do in healthcare all the time, continually review what we're doing and revise it if it's not working. That old CQI circle really does matter when it comes to working in this area. I think I'll end with, as I see my time going, I think I'll end with a couple of things just to kind of leave on your radar. Social determinants of health is a term that we throw around a lot these days. There are 2 important parts of that, though, that I think beyond the stable housing and food and nutrition and exercise and good access to health care and education and employment and other things, there are 2 things that still really cause us great problems when it comes to addressing them. One of them is poverty. We have not yet asserted the notion, the role that poverty plays in poor health outcomes. We see poverty as something that we can't fix, and therefore we set it aside. That can no longer be the order of the day. The other thing, and maybe it's come into light more recently with all of the challenges that we face around some social issues of the day, structural racism, however it plays out, impacts one's ability to both receive good health care, to benefit from that health care when it's available, and to make it available when it's not. And those are two things, sustained poverty and structural racism, that we have got to get a handle on if we're going to be successful in translating the research that is going on in the health inequity area into better policy and public health practice to support the kinds of changes we want to see in health care. At the end of the day, health equity just means that everyone should have a fair and just opportunity to be healthier. This requires that we all play our role in removing obstacles to health, such as those things I just talked about and their consequences, that we attend to the issue of power and privilege and the role that it has in influencing the development of inequality and inequity, and that we look for ways to address those social determinants of health in a meaningful, productive way to achieve the outcome of better health for all. Thank you.